In the first, Dr. Sreeni will be talking about mistakes in the management of red eye. It's very important in perspective. Sometimes the conjunctivitis is so much confusing, and the drug allergy, especially these things are a lot. It increases patient distress. Sreeni.
Thank you, sir. See, you have done a clean phacoemulsification, and you are happy. The patient is happy, and the patient had very clean eye, had 6/6 vision. But see, a patient comes to you after a few weeks or months with a red eye. The biggest mistake that you can make is to not suspect low-grade endophthalmitis in these cases. You had to examine the patient, look for AC reaction. You have to dilate the pupil and look for plaques like this, which might suggest a propionibacterium infection there. See, I had a patient about 15 years back. Uneventful surgery, patient was happy, and the patient came back to me after 3 months with redness. Had AC reaction, red eye, and dilated and I saw something like this. It was looking like a cortex behind the iris. I thought maybe it's a cortex that I left back during the surgery. So you always hope and believe that nothing really bad happens to you. So I took up the patient for AC wash. The next day, I was still red. AC reaction was there. The next day, again that cortex came back, and finally turned out to be fungal endophthalmitis. See, in all these cases, you have to do a vitreous trap, give intravitreal injection, vancomycin alone, or depending on your suspicion, voriconazole also. You might have to do vitrectomy, might have to remove the capsular bag also in these cases. It could be, as Sir said, conjunctivitis also. Again, you've done a clean surgery. I was absolutely quiet, and the patient comes back with red eye, maybe 10 days or 2 weeks later. The mistakes that you can make during this period is not to think of keratitis medicamentosa, not thinking of allergy, not confirming if the patient was using steroids properly, not looking for retained lens material, and the biggest mistake is to not consider endophthalmitis early. The patient comes with redness, foreign body sensation, pain, watering, blurring. You have corneal staining like this. It could probably be toxicity to NSAIDs that you're using. But see, there are instances when endophthalmitis, because of the epithelial edema, can also look like that. The AC reaction, AC cells, AVF cells, and all might be missed. So if you're really suspecting toxicity, stop NSAIDs, give frequent lubricating drops, but don't make the mistake of not thinking that it might be endophthalmitis. And if it is improving, fine. Otherwise, you should consider endophthalmitis in this case. See, tropical cell allergy, tropical cell plus allergy is quite common, and you usually find it out before surgery, but sometimes it might appear after surgery. So this also has to be considered, and allergy to aminoglycoside, neomycin, and all are to be considered. Another big mistake. See, we are in the habit of giving a lot of topical drops after cataract surgery, and the patient might miss one of these drops. And the drop that they might be missing could be steroid. And some surgeons are in the habit of stopping steroids very early also. So in these cases, there can be rebound uveitis. So don't make the mistake of not inquiring if the patient has been using steroids properly postoperatively. Again, this mistake should not be made. The patient has red eye, is a reaction, and has a localized corneal edema. See, this actually suggests retained lens matter. Basically, small bit of nucleus that you do a phaco in a hard cataract. The pupil comes down at the end of the surgery, and you might have arcus senilis, which hides those small bits of nucleus at the end of the surgery. And because the pupil has come down, you're not seeing the small bit. And this might come back with redness and localized cornea. We always look for a small bit of nuclei in the angle in case of red eye. The biggest mistake is that not suspecting endophthalmitis. See, the patient has red eye, AC cells, minimum hypopyon, no vitreous cells. You're relieved. This is not endophthalmitis. No AVF cells, right? Wrong. See, endophthalmitis starts in the anterior chamber, and it spread to vitreous later, but quickly. See, this golden period before it enters the vitreous, that gives a maximum results on treatment. So all early onset inflammation with hypopyon are to be treated as endophthalmitis, and don't make the mistake of thinking that this is just an AC reaction. Another big mistake. See, you feel that the infection is limited because there are no AVF cells. The infection is limited to the anterior chamber, and you can control the infection by giving an AC wash with antibiotic. Again, wrong. Because the echo's turnover time is so fast, and the antibiotic concentration falls below the MIC in a very short time. There will be no time for the antibiotic to act. And this time, because the turnover time is much lesser than the bacterial mitotic time, whatever you're giving into the anterior chamber doesn't work at all. And moreover, you are doing a lot of AC manipulation. While giving the AC wash, you will be pulling off all the membrane and all. And this increases the inflammation, makes it difficult to assess the antibiotic response. So avoid this mistake and give an intravitreal injection. Because the vitreous acts as a reservoir for the antibiotic that you've given, and it stays high for 24 to 48 hours, which is more than most bacterial cycling time. Another big mistake. Clinically, you're sure that it is endophthalmitis. So confirm you're doing a B scan. But in B scan, you're not seeing any echo. You're always hoping and believing that the worst won't happen to you. So you get a chance, okay, this is not endophthalmitis. Again, it is wrong, because in early endophthalmitis, the vitreous inflammation is mild or absent and is not picked on B scan. Another problem, something like pseudomonas. It's very fulminant, and it causes rapid liquefactive necrosis, and the vitreous become echolucent. So don't make the mistake. You should suspect endophthalmitis, take a vitreous tab and give intravitreal injection. Immediate post-op, you have patient with red eye. See, the mistakes that you can make at this stage is not to differentiate between TAS and endophthalmitis. See, something like this on the first post-operative day, you really hope and pray to God it doesn't end up like this. See, that reaction, the severe reaction, could be sterile inflammation, and it comes in clusters. Because it is coming in clusters, you can't think that it is going to be just sterile, because cluster endophthalmitis of pseudomonas and fulminant infection, it comes in clusters. So you have to suspect infection also in this case. So TAS, the red eye, is not really corresponding to the AC reaction. Pain, chemosis, lid edema, AVF cells are not usually there. If it is really severe, the pupil will be dilated and fixed. IOP would be very high. You have, in the previous OT days, you have more cases with more than normal, whatever reaction you are having, more than normal, that reaction would be there, and there will be a limbus to limbus corneal edema. Unlike that, endophthalmitis, they'll usually have pain. I will be really congested. There will be chemosis, lid edema. Pupil, unlike in TAS, won't be dilated. It will be normal or constricted. IOP is not really high. Corneal edema is not as such. So this is it. So whatever it is, you have to admit these cases, give intensive topical and systemic steroids. If it is improving and not worsening, it is TAS. The organisms that cause such inflammation in the early phase, like Pseudomonas, they won't improve at all. They'll start worsening within minutes or hours. So, any doubt of worsening, take a vitreous tap, give intravitreal injection, and refer to the retinal surgeon to be tackled before the cornea becomes opaque. So, please don't make the mistake of missing endophthalmitis in cases of postoperative red eyes. Thank you.